Thank you everyone for joining us for our workshop day today, the Down Syndrome Association of Greater Charlotte. I'm here to present Susie Crain, who has a certified consulting something in speech language pathology. I don't know what all the C's mean, I'm sorry. She is with Child and Family Development. She's currently the Business Development Manager, so she'll explain to you her role a little bit better. But Child and Family Development is a therapy provider in the Greater Charlotte area. They've been for 36 years, and 37 now. They had a birthday. And they do pretty much everything that you would want. They run the gamut. But their mission statement says it all: to provide comprehensive, quality, and integrative services to you. So Susie's going to tell us about speech therapy versus feeding therapy and what that all entails. So, Susie.
Thank you.
You're welcome.
I am glad to be here, for sure. I do work at Child and Family Development. We were founded in 1980, so 37 years ago, by two women who had a mission to kind of have a holistic approach to helping families. And one was an educator and one was a physical therapist, and in those early years, they quickly grew to be a multidisciplinary practice that includes speech therapy, occupational therapy, physical therapy, as well as psychology and education services. So we've been at it a long time, and we've been multidisciplinary for a long time, and I like to say that our mission has been the same since way back then. Really, the heart of the place is the same, even though, of course, over the years, healthcare has changed and continues to change quite a bit. Technology, our staff has grown, and even the types of services that are popular or in demand has evolved over time. We serve children, certainly lots of birth to 5 age kiddos like are in your family, also teenagers and really even into young adulthood. So probably part of what I'll talk about, but if we have time I can tell you about the other services. They kind of run the gamut. So a lot of families, a lot of kiddos kind of grow up with Child and Family Development. They might start out in early intervention types of services. They might go do other things, and then at key points in their childhood or moving through adolescence, they might come back and visit us for different reasons. We have 2 offices. One, our Midtown office, is near Park Road Shopping Center, and our other office is in Pineville, near CMC Pineville. And across those 2 locations, there are about 35 providers across those 5 disciplines I mentioned, including, probably 8 speech therapists on our team. We do have a long-standing relationship with the Down Syndrome Association of Greater Charlotte. Over the years, we have led presentations at some of the dad events, some of the mom-only events, new parent brunches, buddy walks, the 321 dashes. Last year at the conference, we led a half-day segment for teens and young adults, and we've developed and offered programs for teens and young adults with your group. So I have invested a lot of respect for the group and all the great work that they do in our community. Lots of families from the Down Syndrome Association bring their kiddos to us. And some of those families are very active in this organization. So, let's see.
A little bit blurry. There it is.
Our topic today is speech therapy and feeding therapy, and what the similarities are and what the differences are. I wanted to say, to catch on what she said, my current role is Business Development Manager. I started working for Child and Family in 1999 as a speech therapist. And so I saw lots of kiddos, lots of clients. Since 2012, I have not really practiced as a speech therapist, so one of my disclaimers today is that I'm not here to give you specific advice on your kiddos, but give you a lot of information, and based on what I share today, if you want particular advice, I would say start with your pediatrician, talk with your therapist if you have one, or I can help you get connected with one of the members on our team. We do have some key therapists on our team who are trained in some of the approaches that we're going to be talking about. 3 of them are listed there, and there's other folks as well. Let's see. So, as we go through, maybe if I answer a question with I don't know, it's because I'm not quite sure what the latest and greatest is to tell you. Okay. So, people with Down syndrome typically move through typical child development phases, just like typically developing children. They might do that at a slower pace, and that's something you might hear me say repeatedly today. Of course, every kiddo is going to present a little bit differently, and by present, I mean, how they show up in the doctor's office or in the therapist's room, or to a teacher in a classroom. But some of the common characteristics when we think about people with Down syndrome, those definitely do affect speech sometimes and affect swallowing and eating abilities. So I've listed some of them here. And therapies would focus on all these, feeding and speech therapy would focus on providing a lot of opportunities to kids and just repetition of skill building, and that's what they would recommend to you all to practice at home regularly. That repetition and the repetition is what's going to lead to more diverse and richer skills and when it comes to their speech articulation as well as mealtime skills. So if any of these characteristics are present in your child, it might impact breathing and respiration. It might impact their overall strength and coordination in their mouth and other body parts like their arms, hands, and core. And it might impact their attention to tasks like a communication task or mealtime task, following directions, and their willingness to participate in any particular task. So my advice, especially for you're all have little ones at home, start assessments and start treatment early, that early intervention. That will make a big difference in short-term outcomes and long-term outcomes. We once had a family self-refer while their child was in utero. So they knew what the diagnosis would be, and they started coming, I think, 2 or 3 weeks after the child was born to address anticipated feeding difficulties. And that was a success.
Do you all consult with any lactation consultants so that, because I've heard that breastfeeding is really best for development of the palate, the soft palate, and the hard palate of infants. So do you have anybody that you consult with?
We don't work with anyone exclusively. I know some pediatricians in the area have providers, have lactation specialists as part of their team, so we'll make families aware of that and sometimes share information with those people.
So I think that's like early feeding therapy and speech therapy to get all those muscles working, coordinating together.
Yeah, and We are in regular communication with OBGYNs, just, really trying to promote awareness and provide education about getting families connected with the resources in the hospital. Or the particular pediatrician offices that have that type of staff as well.
Okay, good, thank you.
Yeah. So at birth, babies or infants, they might have low muscle tone throughout their body or in their mouth. That impacts their ability to learn to sit and developing core strength. There may be difficulties with the suck, swallow, breathe pattern that can lead to problems with intake, whether breastfeeding or bottle feeding. And then, sensitive. Moving on to using a cup in foods. And with babies, we might see kind of what looks like excessive drooling. That really may be kind of just an inability to manage saliva that's in their mouth. So, in childhood, that low tone would show up as clumsiness sometimes or decreased coordination. Again, what's happening in their body, all the muscles in their body, is also what's happening in their mouth, and you might still see that drooling. And some of the interventions that we will review, will help to address that as well. We all develop motor skills that help us move over time. Gross motor has to do with kind of larger body part movements, your legs and your arms. Fine motor is just a bit more refined, having to do with hands, fingers, toes, and then fine motor skills of all the muscles in your mouth, which help you talk and eat. So in recent years, and kind of in preparing for this talk, I was conferring with some of the therapists on our team, and one thing, a few of them said that in recent years they've noticed that a change in that presentation for the little kiddos. So before there was the Back to Sleep campaign, kids would often present with their tongue kind of protruding out of their mouth, and that got in the way of eating sometimes. That got in the way of making some speech sounds or having clear speech. And they have noticed since the campaign for Back to Sleep, obviously one of the disadvantages of that is kids have less tummy time and are in literally different body positions for most of their day. So instead of it being protruding, it might be kind of bunched in the back. And if you think about gravity, if you're on your back, kind of where your tongue is going to go, or if you're on your tummy, where is your tongue going to go? And so that's been interesting, and I was a little bit surprised to hear them talk about how much they've changed. That presentation has changed. Do you notice one or the other in your kiddos? Not necessarily way out or not necessarily good. Okay. So really, regardless of, the most important part is like, where is your tongue in your mouth? And if it is way in front, way in back, or kind of at rest in the middle of your mouth, that's probably one of the most important part of your mouth that's going to dictate what your speech is like or what your eating, swallowing is like. And like we'll get into more detail about with any of speaking or eating, if your tongue is in your way, especially if it's in your way of breathing or eating, your body's going to choose breathing always, which is a good thing. So speech and eating, we're really using our same body parts, right? Within your respiratory system, you're using your airway, lungs, nose, mouth, and core. Your airway, you think about for an adult woman, your airway is about the size of your index finger, very small. And for a child, like maybe a 4-year-old child, you think about it being about the size of a pinky. So there's not a lot of space back there to manage all that coordination of breathing or eating, or if your tongue is in your way, just to kind of manage that as well. Here's the handouts. For speech and eating, we're obviously using our oral cavity, our mouth, and there's lots and lots of different parts of the mouth that we don't necessarily think about when we're in the process of doing one of those things. Your lips, your cheeks, your gums, your teeth, soft palate, hard palate, tongue, and the pharynx, the larynx, and your airway. All of those parts have to work together to make things run smoothly. So really, regardless of whether it's speech therapy or feeding therapy, some of the treatment focuses are going to be the same. That's body part awareness, sensation of those different body parts, how strong they are, or building strength, and building coordination. So when you're moving them in a smooth, sequential way, and use. So almost always, especially for kids with Down syndrome who are presenting with decreased awareness or decreased strength, there's going to be a focus on improving oral motor in speech therapy. So speech therapy, let me say one more thing about this. When we're talking about is it speech therapy or is it feeding therapy, kind of the inside joke is that you can't do anything without doing speech therapy because pretty much any kind of interaction that you have is going to include communication. So just like at home, it's not as if you would think, oh, it's snack time and walk by your kid and kind of shove a cookie in your mouth. You're going to have some conversation about it's snack time, do you want this or that? And that's probably, that's what we're thinking during feeding therapy sessions. There's always some work on communication, whether it's verbal expression or comprehension. But we would always include that focus on motor skills, kind of like thinking about it as weightlifting for your mouth to build strength, or Zumba for your mouth to build that coordination and skills. So speech therapy, people get confused about this, is also known as speech language therapy. Sometimes a speech therapist is known as a speech language pathologist or a speech pathologist, and that is all the same thing. It doesn't mean one person has a different credential than another. A certificate of clinical competence is what that stands for.
All of those C's.
All those C's.
I used to know what those meant. They just weren't coming to me at that moment.
So, by law, we have to have our C's. Not every speech therapist is going to be trained in helping your children with feeding in particular, and there are, of course, we learn about it in school, and they probably do more learning about it these days than they did even 10 years ago or so, because there's been such an emphasis on addressing that. So that's a good thing. But if you're looking for a pediatric speech therapist to help your child with feeding or swallowing skills in particular, or particular difficulties in their actual speech, their actual expression, then you may want to find one who is trained in a particular method, and we'll be talking about some of those today. So speech therapy in general includes, is all about your mouth movements, especially, guess which one? The tongue. The tongue moving front to back, side to side, up and down. To generate speech, we have to press our lips together. We have to put our teeth in certain contact with other parts of our mouth. We have to control nasality, or breath, in and out of our nose to make sounds and to turn your voice on and off for sounds to come out correctly. So you all have a handout about speech development. You guys, oh, you do have, yeah. That is just a general list, reference of speech sounds and the order in which they are typically developed. Kind of a mastery age there. So even the first one, that M sound, is a nasal sound. If we M, or the N sound and the NG, like song, where we don't necessarily consciously think about, let me turn my nasality on, but we have to be able to control that, grade that on and off. Voiced and the voiceless sounds, and usually there's a minimal pair or two sounds that go together. You make in the same way, but with one you have your voice on, and with one you have your voice off, or it's voiced or voiceless. So the number 2 and number 3 are a good example. Puh and buh. That we make those in the same way by kind of pushing our lips together and bursting air, but one has your voice, the B, and one does not. Same with T and D, with K and G. With T and D, try making a D, duh. And when you do that, you're putting your tongue tip behind your 2 front teeth and turning your voice on. When you make a T, it's exactly the same movement with no voice. So those kind of go together, and thinking about mastery of sounds, you can see we see those kind of developing at the same time. Those Y's are tricky, R's and L's are tricky, so you really, with a typically developing child, we really don't expect kids to master all sounds until they're about 7. So there's a lot of wiggle room there in when you might start to hear them. And kids with Down syndrome might master these sounds in the same order, but it might be beyond 7 years. So you may know during child development there are a lot of common sound substitutions, simplifications, like 2 sounds together like a TR, like it would not be uncommon for a kiddo just to say T. So for truck, you might just say tuck. They might use sounds that they have mastered and substitute for sounds that they have not yet mastered, like an F for a TH, for example. So also, if you notice your child doing that, that could just be a typical developmental process. But I would say probably for young kiddos enrolled in speech therapy, a therapist would definitely be working on sound production as part of their therapy. And we generally do that in a hierarchical manner where they're just working on the sound first, like a K, which we make way in the back of our mouth. They might just work on the K, which work on getting your tongue in the right position for that. Then pairing it with a vowel, like he, ko, then a word, like usually at the beginning of a word, like coat or cake, which has it in both places. Then moving on to short phrases like I want cake or coat please. And each time you move through that hierarchy, it's just a more complex task. So we want to see mastery at the most basic skill first before we're moving on from. And related to that, which I also think is real common for kids with Down syndrome as they're getting older, we are always working on intelligibility, so clarity of speech, and how clear is their speech to very familiar listeners like moms and dads, to a less familiar listener like maybe a classmate, and then to a totally unfamiliar listener. So that's a long-term goal for most kiddos, but an important one. So speech therapy also can include auditory processing, general communication skills, expressive language, which we talked about a little bit, and receptive language, meaning comprehension of other people's communication, oral motor for speech and for eating, phonological awareness, kind of being able to identify sounds or identify mistakes or oddities in other people's speech and still be able to get the intent of what's being discussed, phonological processing, and voice and fluency. Voice can be related to volume, so having we want to have a appropriate volume, and sometimes it can be low or high, tone of voice, and fluency is kind of another word for, or disfluency is another word for stuttering. So we want to have fluent speech, which helps with overall intelligibility.
What's the difference between auditory processing and phonological processing?
Auditory processing is broader, has more to do with kind of executive function level skills. For younger kids, some of that sound discrimination, discriminating between, let's say, cat and hat. So if somebody was reading a book to them or telling them a story, even on purpose, we might do this in therapy, he put his cat on his head, and being able to understand that that's a joke or, an error. It has to do with memory, so being able to retain, early on, just retain a series of numbers, not 7 or 10 for a phone number, but which none of us do anyway these days. Remember a number like go get 3 apples, and word memory, so kind of being able to retain information and use it later. And it gets more and more complex from there as kiddos get older. Speech therapy is usually provided one-on-one. That's probably what most people are familiar with. These days, I believe kind of the usual and customary is a 30-minute session, whether you're getting a service from school or in a private practice. But sometimes, especially if you're working on multiple skill areas like speech and feeding, you might request a longer session.
Susie, how is that 30 minutes determined? I mean, is that based on child's attention span, the scope of work, or is that an insurance-led thing?
Well, I knew when I said that somebody would ask me that question.
Leave it to Catherine.
And I knew it was going to be you. I mean, of course, first and foremost, the child's presentation is going to be what's taken into account. So, a lot of parents, frankly, might be like, I want an hour because an hour must mean it's better, it's more. And some kids don't have the endurance for
Right.
1 hour of therapy, don't have the stamina for that. So that's, one reason why that would be probably the first determining factor. But these days, the reimbursement rate that most insurance companies, that North Carolina Medicaid, give to providers is equivalent to
30 minutes.
30 minutes of their time. I hate to say it that way, but
Yeah.
which is why I was saying if there are goals or if there's an authorization, if that applies to your funding source, to work on speech therapy and feeding therapy, which we'll talk about next in a little more detail, then there might be more of a justification for a longer session. Or for a child who requires a lot of time to prepare to attend to a therapy task, like kids who have a feeding tube or are in a wheelchair or need some other postural support where before you can even start the therapy part, you've got to kind of get set up for the work. So those are some of the reasons why.
Thank you.
I don't know that that's going to change anytime soon.
Yeah.
But that's kind of the norm these days. And I can't speak to the public schools that much, what their rationales are, but I am aware that most of the IEPs that I see say 30-minute sessions.
Yeah. I think as a parent, part of the concern, and of course Cameron's 12, but in school, by the time they get him out of the classroom, take him to the room, he settles down, they start, now he has a 20-minute session, and even in private speech therapy, sometimes there's still that 5 or 10 minutes of, okay, quit messing around now, and, so sometimes, to me, again, but Cameron is older, 30 minutes doesn't seem to actually equate to 30 minutes. Sometimes he's just getting on a roll, and, okay, now it's 30 minutes, and that's when we stop.
Yeah. Part of the art of being a good therapist is maximizing, every moment you're with the kid. So that walk from the lobby to the therapy room
That makes sense, yeah.
the classroom to the therapy room shouldn't be like, let's go. You should be working on stuff and at Child and Family. I think we do that certainly, partially because every inch of that office is therapeutic in some way. We use every inch of our space for sure. I had another thought about that I forgot it.
Sorry, I derailed you there.
So, if you're having that discussion with your provider, maybe, or just thinking about how you're using your benefits, you could, most of the time, insurance companies don't limit how frequently you can receive service. So if it's clinically appropriate, you might ramp up the frequency, meaning 2 times a week or 3 times a week, and that might be an argument, so to speak, to request with your provider, whether it's in school or private. So mostly one-on-one, lots of places including us. We do small groups, kind of language-based social skills groups. We do some of those that are just speech therapist-led. We do a lot that are co-led by a speech therapist and an occupational therapist, so you kind of got that speech, language, and sensory motor stuff happening at the same time, which is good stuff. And specialty programs kind of specific to speech therapy include Prompt, and there's a side handout there about Prompt therapies. That's one of those specialty certifications that certainly not every speech therapist has. I believe their website has a list of providers. One of our SLPs is Prompt trained, and I think there are at least a few others in our community.
Very few. Well, very few according to the Prompt website.
Yeah. So that approach is kind of a regimented approach to skill building with the oral motor and building language in the way that we were talking about before, kind of starting at the sound and working your way up. Really an emphasis on increasing verbal expression. What you're reading on your handout, their description is manipulating and shaping the oromotor structures to help produce a sound. It provides multisensory information, tactile cues, so touch cues, auditory cues, and visual cues to your speech system to help generate sound production, then words, and so on. And another one is called Hanen. Also, that requires training or certification to offer it as a service. That one is probably for older kids, so 2, 3, 4 and up, a little bit older. It's actually more for parent training, although, let's see. So it teaches parents how to create and maximize communication opportunities in everyday life. So the kiddo, there's some videotaped sessions with the therapist and the parent and the child, and then you take that home and kind of replicate and build on those scenarios over a several week period. So that one kind of has a start and end time. We have 2 therapists who are trained in Hanen. We've had a hard time getting a number of parents who want to do it at the same time, and it is kind of a group activity. So I think really we've kind of gone through the whole program as a group one time, but these ladies incorporate what they know into their one-on-one sessions too. And I'm aware, I think it was last year, that a Hanen training was offered here in Charlotte. So there are probably not a ton of providers here, but some providers here that are Hanen trained and might offer that service.
So let us know when you're planning another one of those, because I bet you that there's a lot of young parents of young children in our association that might be interested in doing something like that.
Well, the nice thing about working in a private practice is we we have a lot of flexibility in when we can offer stuff. I'm trying to see if this one doesn't say a particular number of families, or does it? Usually there's kind of a minimum number of families to get a group going, and once we have it, we could offer it right away. But I'll follow up with you about that.
Good.
It
She
says
found
four.
it on there.
4 families, okay. So, Talk Tools is another popular protocol that probably quite a few SLPs have some experience with. You don't have to have necessarily the particular training. I don't think they offer a certification. But, you know, if you're
I think
talking,
they do actually, Talk Tools, they've got,
they have.
yeah.
This is not a Talk Tools bag in particular, but they have a kind of a very regimented grouping of tools.
They look a lot similar to
Yeah,
that.
tubes, whistles, I mean things where you're like, is that a hair roller? What is that? And they practice certain oral motor, oral sensory skill building with those tools. And, you know, if any of us do anything in a regimented way, we're going to see a result for sure. So it's not to say like, go find someone with one of these trainings, but they are helpful in having very goal-directed therapy. And Talk Tools does have a course that's more focused on feeding now.
Yeah, they have like different levels of certification, and I think they go all the way up to level 4, which is when you can train other providers to then give their sort of protocols and therapies. Kelsey did one time with oral motor stimulation, and you mentioned about weightlifting for your mouth, and honest to God, it really was. It was like, put your tongue over here this many times and try to move this ball forward or backwards.
Yeah.
It was kind of like that tongue sweep kind of thing. And I think Cameron has done some Talk Tools and
Cameron's
chiseled out
done
his
all.
cheeks,
He's done it
right?
all, yeah.
Yeah, so.
And we
yeah,
still
pretty
use
crazy.
some of everything.
Yeah.
Yeah.
You know, that's a good point, and I mean, we haven't really even gotten to the feeding therapy part yet, but I think there's a good balance there in, you know, being comfortable with your provider, with your therapist, number one, but, you know, somebody who can incorporate all these areas of expertise, like prompt or Talk Tools or some of the other things we're going to talk about, but not be so regimented that they can't adapt even in a particular session to support your child. So some of them, just the nature of the protocol, it's like 1, 2, 3, and so you're going to stick to that very specifically. But you know what I was saying about making the most of every moment of a session, you're going to kind of create some communication opportunities on that walk back to the room. Deborah Beckman, Oral Motor Protocol, is another one that is old school. And some of the philosophies, some of the strategies, they are the same things that we see in some of these newer protocols. So it's definitely, for some kids, one might be more beneficial than another, but that's another good kind of tool in someone's kit to help kids with speech and feeding. And this is out of the ordinary, but look for a speech therapist with training in neurodevelopment. Particularly, there's NDT certification. Not many speech therapists have that. Many more OTs and PTs have that. Ann Guild is one of maybe the only NDT certified speech therapist in our community. It is a very rigorous certification, and people can be trained or certified, and both are good. But NDT is great for little ones, great for everyone, but particularly useful when kiddos are little and working on appropriate posture for speech, for mealtime. So it has a lot to do with neuromuscular strengthening, so appropriate posture or positioning your child appropriately in various daily activities, even like bath time, or an NDT trained therapist would probably give you suggestions on what to do on the changing table to kind of help your child build up muscle tone and core strength. So might be hard to find a speech therapist, but that's a good skill set to have. In our practice, we're multidisciplinary, so speech therapists, occupational therapists, and physical therapists. We're under one roof, or two, depending on which location you're visiting. We are constantly collaborating and sharing with one another, even when a child is not necessarily enrolled in all of those services. So our speech therapists might have the benefit of getting some advice on posture, advice on building motor skills during that 30-minute session. And in our practice, and I think this is common in our community, occupational therapists can be very involved in feeding. Therapies, it's gray, but we kind of separate this by something from hand to mouth, from the plate to your mouth is more occupational therapy, and once it's in your mouth, it's speech therapy. But you want to find a therapist who is kind of comfortable with the whole experience. So the OTs obviously are going to be working on communication and stuff too. They might be instructing on some of those oral motor weightlifting types of activities, but they probably won't be talking a lot about actual swallowing. But really, for more speech therapy stuff, OTs might work on behavior, motor planning, sensory processing, which can definitely impact your communication skills or your feeding skills, and visual perception. So we do a lot of collaborating. Speech therapists do offer feeding therapy, also known as speech therapy. An occupational therapist could have a feeding therapy session. You might hear people refer to it as mealtime therapy, and there are many specialty approaches and protocols. So I guess don't get too hung up on the label or the semantics of it. I think I probably at work I would refer to it as speech therapy or occupational therapy, but for our purposes today, feeding therapy. And a speech therapist's goal is going to be to move liquids or solids into your mouth and safely all the way into your stomach. So a lot happening in this area. Helping kids thrive, so maintaining an appropriate weight, maintaining adequate nutrition and health. For little ones, a doctor, a pediatrician might identify failure to thrive if a child is very underweight or if they're not getting adequate nutrition from oral intake. So we want thriving. A physician might recommend G-tubes, feeding tubes, temporary or permanent if that's happening. They might recommend supplements to regular meal times, which have some obvious benefits, but also can present some challenges in helping a kiddo become a more independent thriver, more independent with eating and drinking. Feeding therapy will focus on a diet, so trying to work towards a child consuming a variety of textured foods, so not just soft, not just crunchy, mostly being okay with some mixed textures, various temperatures, cold, hot, room temp, various colors of foods, believe it or not, and of course foods, having a diet from all of our different food groups. It's obviously okay to have food preferences and even dislikes and favorites, but the important key is that any of those things don't restrict your intake excessively or restrict your health. I think we could probably all think of things we really don't like to eat, or some
Lima beans.
people don't like their food to touch on their plate, or those kinds of things, and those are within normal limits. We get concerned when there's when it impacts their health, or when it impacts normal life.
Culturally accepted practices.
Yeah. So with, feeding therapy, also mouth movements, y'all are gonna get tired of me saying that. Early on, coordinating the suck, swallow, breathe for breastfeeding or bottle feeding. If the tongue comes forward, like we were talking about, kind of an over protrusion, or if it's kind of bunched in the back of someone's mouth, the therapy might focus on, moving it to a more neutral position inside your mouth and being able to move your tongue towards the front, towards the back, side to side,
Sweep that
up and down. It will work on jaw stability, and how your jaw and your teeth work together for eating, chewing, up and down movements, lots of work on biting in some of those protocols we talked about. Your palate moving properly during the oral phase of the swallowing process. And not that a speech therapist can really train your pharynx and larynx what to do, but want to make sure that your airway is protected while you're eating or drinking, so you don't aspirate, have something go into your lungs that doesn't belong there. And not that a speech therapist is going to do any esophageal training exactly, but we do want that body part to be working properly to kind of move the food down into the tummy. So it's complicated. A lot more than what we might think, and that safety is key. And I think we could all probably think of times when we've had a hard time with something while we're trying to eat it. Like that's what happens in the break room at my workplace during lunch. We observe our coworkers or we're so self-aware that we're like, oh, I'm on a food jag. I'm only eating, rice and beans this week or something. Or people who, won't eat a raspberry because of the fuzz on the outside or something like that. Sticking a big piece of sushi in your mouth. And then, kind of thinking, now how am I going to chew this up and swallow it? So that kind of sensation is what your child might be feeling during a regular old mealtime. Might feel like, whoa, what is this in my mouth and what do I need to do with it to get safe again? That's that, kind of breathing first mentality of what we were talking about before. Even this morning, I got one of those assorted fruit, like pre-cut fruit where all you have to do is eat it. I was eating a little slice of kiwi and I was like, I can't tear this up and chew it in my mouth. So started to give it to my dog and he won't like it either, but you'll be surprised if you work surrounded by therapists like I do. You'll get analyzed, number one, but you might start to notice it in your own experience too. The more you know about it.
Susie, these skills, can a child lose them? So, Cameron has verbal apraxia as well as Down syndrome, and he has been through feeding therapy. He had like 6 months of feeding therapy after we had talk tools come in and present, and we realized our kid didn't chew. He basically shoved food in his mouth and swallowed.
Yeah.
And we thought he ate well because he ate lots of food. And we're finding in the last probably 6 months that there's excessive drooling when he's eating. Sometimes he just doesn't bother to swallow. He'll leave food in his mouth for a while. And we honestly don't know if it's behavioral or if it's a feeding thing. But is it possible that some of these oral motor things that get developed during feeding therapy, that 6 years later, we could actually have a problem with it again?
Well, you kind of beat me to it.
Sorry.
I think the answer is yes. I mean, it's, if we think about it like bodybuilding or weightlifting, once you stop doing it,
Yeah.
your tone gets reduced. You develop, all of us do this for all kinds of things. We develop compensatory strategies, like I'll just leave that tucked into my cheek and, or am I even aware that that's still there? That's a safety issue.
Right.
The speech therapists were telling me, one very common presentation is overstuffing, like a big piece of sushi. Well, for me.
For adults.
Yeah. They will overstuff or because the more that's in there, they have more sensation of, okay, something's in my mouth, I need to push it back, and
Yeah, he does that too.
and I mean that's not a good strategy to have, but they'll do that because they can kind of feel it more and know, okay, I've got work to do. The mouth knows I've got work to do. I can't breathe very easily when all of this stuff is in my mouth, and they'll gulp instead of chewing up and swallowing in some cases. So, yeah, I mean, I think there can be regression or loss of skills.
So evaluation time. Okay, got it.
And
Maybe laziness.
On his part?
Yeah.
Yeah, and that's just it,
some of that
Cam.
inattention.
Well, and Cam has his unique set of behavioral issues, so sometimes I don't know if that's what it is. He just, I don't want to take this pill, so I'm not going to swallow it. I'm going to leave it in my mouth and watch it drool out the side, and, so that's just it with him. I don't know what it is. But the overstuffing, we see him do that a lot.
Yeah. And there's I don't know that, there's a lot of mealtime rules you can set up, but, you know, another part of this is that you don't want every mealtime to be
Yeah.
a battle or last 2 hours or those kinds of things. So
Yeah.
kind of finding a varied diet that kind of meets nutritional.
Varied
needs.
diet?
Varied.
Every meal is not chicken nuggets? What?
From McDonald's. Yeah,
Oh, no, he doesn't care where they're from.
some kids too.
Yeah. Some
Um,
typically developing kids care where their nuggets come from. I found that out the hard way with some of my kids' friends. My kids.
So, yeah, I mean, I think that's what we're going to talk about, this SOS approach.
Okay.
One of these other trainings that's kind of all about a varied diet and safety.
Sorry, I jumped ahead.
So in a typically developing person, when we're eating and drinking, or when we're eating, our jaw does go up and down first. You know, we're biting and chewing, and then it begins to use kind of a rotary movement to move the food around in your mouth. Your teeth are doing their job. Your tongue is moving forward and backward to form a bolus of food, or kind of a bringing all the food together, preparing to swallow it. Your tongue then starts to move laterally or side to side, pushing the food, the bolus, to your mouth for chewing. Your tongue moves back to bring the bolus towards the back of your mouth to prepare to swallow. We talked about how small that area can be, so if you have a whole bunch of food in your mouth, it's going to be tougher to swallow a lot at one time. Or if if someone's tongue is kind of low tone, or you know, its at rest position is further back in your mouth, it just creates a safety concern, kind of creates a battle between, am I going to breathe or am I going to swallow this? So you might have somebody spit out food, or you might have a lot of saliva secretions at that time, and you might see drooling then. That might be what's going on. So you're at risk then for keeping the food in your mouth, having some of it scatter over to one side or the other, or having it go down the wrong pipe. Aspirating, we don't want that to happen. You know, or swallowing it safely. After we eat, kind of after each bite, we don't think about doing this consciously, but we do kind of sweep our mouth, or at least every couple bites. Kind of do a sweep of your cheeks or tongue to make sure there's no kind of leftovers in there, and if there is, then we typically just kind of swallow again, take a drink, wash that down, and are able to clear our mouth of any residue. For us, you know, that happens kind of normally, or you are very aware if there's a little bit of food stuck in your cheek, or even if there's something stuck in your tooth or something like that, and it bugs you, and you do what you can to clear your mouth out. So for people with Down syndrome, sometimes they have a different swallowing pattern because of the low tone in their mouth. They might have decreased awareness of the different areas, or of food where is the food in their mouth. They might have decreased strength, so all those parts might not work, might not be able to move the food along as it should, or they might have discoordinated movements, and some of those things that we were talking about, like not forming a bolus, or having a little piece of food off the side, kind of getting stuck in your mouth instead of swallowing it. Their jaw movements tend to be more up and down and less rotary, so it just makes it harder to form that bolus. If there's exceptionally low tone, the food kind of might float to the back of the mouth before you're ready to swallow, putting you at risk for aspiration. And then the common strategy, I don't want to call it a common occurrence, is that you just keep on putting the food in, and when there's more food, you're like, okay, now I can feel it and can start to move it around a little bit easier. Or maybe that, the more I put in, something's going to go to the back and I'm going to have to swallow it. My tongue doesn't have to work so hard to push it back there. But certainly there's an increased choking risk when any of those things are happening. Usually, there are a couple different tests you can do, kids or adults, that can show you what's happening during a swallow. They're not necessarily required tests, but sometimes a speech therapist or a pediatrician or a lactation consultant is going to recommend one. A modified barium swallow study, or an MBS sometimes, is basically like a moving x-ray. Those are done a lot with stroke victims to see the weakness in someone's mouth or throat. But they can be done with anyone. You're just kind of seeing how the parts of your mouth work. You have to swallow barium. It's kind of like milky and it doesn't taste good. But kind of like a video, a moving x-ray. And you can see how the bolus is formed. You can see how the tongue is moving. You can see if there's leftover residue anywhere, and then you can also see if there's any aspiration at all, any trace aspiration, so kind of identify some safety risks. I guess they can mix barium up with food and stuff too, but usually it's liquid or thickened liquid. And there's a test called FEES. I meant to look that up to remind myself what that stood for. But I think the F is fiber optic. They, a tube with a camera on the end is inserted into your nose. So it kind of overlooks bird's eye view of your throat. That one's done mostly when there is a concern about aspiration. You can see really what's like video, what's happening back there, and if there's any residue there, or if it, which tube it's going down. So, feeding therapy is going to focus on some mealtime strategies. Hopefully, or eventually, those are going to be like natural occurrences, family dinner time, or at least that's, kind of the long-term goal, and not necessarily something separately that you have to do with your child outside of your family meal times. In therapy, like in SOS therapy, there's a lot of emphasis on rewarding desired behaviors and having there be a consequence for undesired behaviors, but not using negative punishment. We don't want to punish kiddos for adaptive behaviors like protecting their airway. So if they don't feel safe, that might be the reason they're not swallowing the food or spitting out their food, and punishing, so we wouldn't punish someone for doing that. We really want to teach them about foods and what to do when they have those unsafe moments. And we do that through some specialty programs like sequential oral sensory approach or SOS approach. That's a very popular approach these days with speech therapists and occupational therapists. I don't know that there's certification, maybe there is, but you can also just take a variety of courses to learn about that approach.
Sensory oral.
Sequential oral sensory approach. That is out of the STAR Institute in Denver, Colorado. And they have, very intensive camps, like week-long camps that kids might go to.
Mm-hmm.
And the SOS sessions definitely can be done one-on-one, but they're kind of fun and therapeutic to do in small group, like group of two kids, two therapists, or two kids, one therapist. So the kids can kind of encourage each other. The SOS approach is all about texture, temperature, color, food group. And I mean, if we have time, I can go into a little bit more detail about what one of those sessions is like. There's a training called Vital STEM, or an approach called Vital STEM. That requires certification. The speech therapist is attaching electrodes to this area and kind of stimulating a swallow or a muscle response if this area is weak. That can help teach someone how to swallow. Top tools we talked about, and that NDT certification, which is not so much about feeding or eating itself, but is kind of about setting up your body so you're ready to do it safely. So,
NDT was neurodevelopment.
neurodevelopmental treatment. I think the website is ndta.org. So having a PT or an OT with some NDT training is going to help your kiddo come mealtime too, even if that person isn't working on eating skills. So services for people with Down syndrome, motor. Motor first, then more motor. So you're a PT and OT, a speech therapist should all be working on a motor component of skill building. Not to say you have to have all those services all the time. Therapists can probably help you prioritize what's most important right now. But there can be a benefit to having coordinated services. We have the luxury of being an in-office provider. We do a lot of coordinated services. So a kiddo might go to OT first, do some body work, get their system ready, and then come over to speech therapy to work on speech or eating. We do co-treatments. That's another question parents have sometimes is like, my kid's getting less therapy if they're co-treating, but you can, really it has to be clinically appropriate first, but having a co-treatment like speech and OT can really enhance the progress that can be made. So, some kids who have very low muscle tone, who don't have good posture, having the OT or PT there to keep that going and stable while you're working on breath support for speech. or moving your mouth in a proper way for speech or for mealtime feeding, that can really be beneficial. So I would encourage you to be open to trying it if that's something that your therapist recommend. And you know, probably at least in a private practice environment, you can mix that up a little bit. You could do some co-treatments and some traditional one-on-one types of therapies.
Our son did PT and speech together
Yeah.
during some treatments, and those were some of his most successful speech therapies.
Yeah,
While doing it with the physical
he's outnumbered, so. Well, you know, everything is connected, so those can be really greatly beneficial for sure. And that, you know, kind of the beauty of having therapists, you know, the PT, when they're not together, the PT can then incorporate some of the stuff she observed from the speech therapist and vice versa. I mean, your PT's not going to be feeding your child. There, for kids with Down syndrome, sometimes there might be a hyposensitivity to some of the strategies we've been talking about, so an under response, or there might be hypersensitivity, like an over response or reaction, especially when part of their medical history includes like feeding tubes, sometimes G tubes, or if they've had medical procedures around their nose or mouth, there might be kind of the sensitivity, and we'll have to address that first before they can jump into working on some of these other approaches. All services and what the therapists are going to be recommending for you all to do at home is what I said at the beginning, just lots of opportunities and repetition of movement and of skills. So you go home with that Top Tools pack, or you go home with some of those prompt cards and so on, and practicing things outside of the therapy session. They're going to say, you know, try this at mealtime or with the SOS approach. If they're, they might be talking to you about, I want to show y'all the slide, playing with the berries, not eating them, not saying you better eat that or you know, you're in trouble, but doing other things with food so that it becomes kind of safe and enjoyable, and eventually you get it here and get it to become part of their varied diet.
Susie, if I can say something about that, if your therapist will let you and lets you video any of your sessions, you know, our kids are so visual, and we found, especially when Cameron first started the prompt therapy, he goes to Child and Family, the stuff the therapist was doing with him was very much touching his face, manipulating his mouth, and then he'd come home and he'd try to move his own mouth when he was talking. And we found that Belinda would let us just, you know, with my phone, record part of what they were doing during the session. So then Cameron would go home and he'd watch himself do it, and then just like he was in therapy again, he'd repeat it back. So if your therapist will allow you to do that, sometimes that's a great way.
I think that's a
as a
great
parent,
idea.
that was so much easier for me than trying to reproduce what she had done to practice with him, because he'd watch it and practice on his own.
So I think that's a great idea, even if, you know, well, like one parent is there but the other one's
Right.
not, or a caregiver is bringing, that video is a great way to also share with the other people that are a part of his life. Because of HIPAA, you know, well, in our office, Melinda would not be making a video and sending it to you.
Right.
So that is something that, you know, bringing that in and asking your therapist.
Right, and we ask her when we do it, so
Yeah.
each time.
Or photos
So,
or whatever might be useful, and they'll probably be giving you verbal or written ideas for things to do as well. At like encouraging oral play at home using a particular kit or using some of these brushes, like teething, almost teething brushes, a Nook brush, but they make some that vibrate. They make some that have different attachments, so kind of getting that variety of stimulation is good. And mostly kids can hold it and kind of give it, do it on their own. These shoes, I guess you could say, this is a Q. And there's one shaped like a P, so.
Or a B.
Or a B.
Depends how you put it.
Oh, that's true. The upside down P,
Okay.
lowercase b. Yeah.
So they'll give you some kind of specific instructions, but even if the kid's just, chewing in the back seat while you ride to church, they're getting that practice and getting some variety of movement. And y'all, like, now there's so many products available that are kind of chewy toys that can sometimes help with that saliva management stuff too. So if somebody has some low tone and they're at rest or sitting in the classroom, riding in the car, most of us are kind of managing our saliva, not really thinking about it, we're swallowing it. But low tone, they might have less awareness, less sensation, and it might come out the front, and they might drool. So having something like this can also keep the swallow going. Just chewing, the act of chewing will kind of stimulate your body most of the time to keep swallowing. So, I mean, they make like pretty fashionable bead necklaces and all kinds of things these days for that. Giving them kind of appropriate things to chew too, instead of chewing on things that are not meant to be chewed.
I think we got all that stuff on Amazon. I mean, it was
Yeah,
very easy to.
it's very available these days. Plastic plastic spoon or a straw, including different kinds of tubing that have kind of different levels of strength, bendability. So some will be very, very chewy. Even buying, I've heard, I guess, buying refrigerator tubing at a hardware store, which is very, very inexpensive. I think that's what this clear one is like a way to have one everywhere you go, like reading glasses. And then put one here, put one here. So having some of that stuff around will help, especially if they're mouthing other things or drooling a lot. Even for older kids, you could use some of those baby products like gauze chewers, gauze pouches. That is like netting. You can insert a flavored ice cube. You could insert a berry. You could insert thick applesauce, so they're getting like some food instant. Yeah. And that's kind of a safe way to chew where it's a bit more controlled than spooning it in, and they can kind of do that independently a little bit, kind of control what's going in and out. If motor skills are not part of your therapy protocol, progress is going to be a lot slower than what you will want. So talk to your therapist about oral motor activities, oral sensory activities, even talking to your PT and OT if those are, or talking to a therapist or a teacher about the benefit of adding in OT or PT, just to prepare the body, to prepare the mouth to do its job. And practice. Start early and practice a lot. Yes, that's going to be required. Here I thought I might not have enough to say. The rest of the slides in here contain a lot of information about picky eating. One of the other pages in your packet, one of those Thrive documents, talks about picky eating versus having a real feeding, swallowing difficulty. So I'd encourage you to kind of check those lists there, and even if your kiddo has a lot of characteristics of being a picky eater, that's something you could talk to a speech therapist about, or an OT.
That myth number 9, that certain foods are only meant to be eaten at certain times of the day. I like that one. Some kids just want to eat
Yeah.
pancakes for dinner.
We'll be found to
That's right.
Some kids want to eat meatballs for breakfast.
And this picky eating versus problem feeders, that is from the STAR Institute. So there's some research behind kind of differentiating which category you fall into. We did talk about common reasons kids won't eat. These are all pretty good reasons not to want to put a bunch of food in your mouth.
Vomiting, sure.
This is what I was referencing before. Steps to eating, these are things, any of these things they might be practicing during an SOS session, which sounds kind of kooky, tolerating having a raspberry in the same room where you are, but sometimes that's where it starts, and then you get to tasting and consuming in most cases. There's a tab about normal oral motor development. Same message, your kids might go through these same phases. They might go through them a little bit slower, and they'll definitely have preferences and dislikes. So if you're not connected with a provider, with a speech therapist, and think you need to be, I would talk with your pediatrician. Lots of places, including Child and Family, you can self-refer mostly. You don't necessarily have to have a doctor's prescription unless your funding source requires it. North Carolina Medicaid does require a doctor's prescription, but most providers can help you get that too. At Child and Family, we do a free phone intake between the therapist and the parent, kind of get the top concerns, get some history to prepare for the 1-hour evaluation session. And then we do a parent conference where we share the results and recommendations, and if treatment is recommended, we will get started. And we love having a multidisciplinary approach. We definitely refer to experts in the community, like your next speaker is from an ABA group. We refer to ABA providers, nutritionists, lactation specialists outside of our practice, and that's kind of what it's all about, to help a kiddo be successful. The last page has my contact information, so if you have questions for me, please feel free to reach out. If you're interested in our services, I listed the office numbers there as well. I'm sorry, I did not leave much time for questions, but I'm planning to stay for the next session, and I guess there's a lunch break, so I'll be around during that time. Thank you.
And we've got 15 minutes before the next group
Okay.
comes in. Well, now we have 10 minutes before the next speakers come in. So there's some break time now if anybody has additional questions. They just won't be recorded.
Thank you.
Thank you.